So without further ado, I would like to introduce our first presenter who will be giving a talk on update on infusion devices used for OPAT or HIS programs. So our first presenter will be Rachel Prasad, who is a cystic fibrosis clinical nurse consultant at Westmead Hospital. She is a clinical nurse consultant with a postgraduate diploma in acute care nursing and has spent the last 3 years working on cystic fibrosis. And she's currently working on adult clinic at Westmead Hospital, which has over 200 patients from around New South Wales. So the service is out of 3 adult clinics in New South Wales who manage CF and assist with further research in CF care. So without further ado, I would like to invite Rachel to share her slide and continue with the talks.
So, I'll talk to you guys today about the uses and the changes a little bit of the electrometrics that we use in CF. So, just to give a brief history of, or a bit of background of who we are, we have a service of a multidisciplinary team. We've got consultants, pharmacists, dietitians, psychologists, physiotherapists, and of course a CNC. What we do is we take care and treatment and management of patients all across New South Wales. We roughly have about 200 patients with ages ranging from 18 to 60. This also includes our bronchiectasis service that we manage as well here at Westmead ALS. So just a quick background of what CF is. It's a genetic condition that is caused by the mutation in a gene. This results in the mutation of the regulation of salt and water through channels. Therefore, it makes a lot of the channels, the most common one is Delta 508. So that basically just means that there's not enough channels for the chloride ions to move in and out. Therefore, it just does lead to thicker secretions. So again, CF is an inherited gene. It does get inherited from either the mother or father. CF in general has had a lot of changes throughout the years, as we can see from our graph here. So by age and the years down the end. So we went from the discovery of the first pathological gene to discovery of the salt test, to making sure the gene's identified, to ongoing different types of treatment for these patients. As you can see, so far it only goes to the 2015, but currently we've had a lot more treatments and medications that have come out to assist in CF treatment and management. Some of the effects of CF, it results in the exocrine mucous glands, they produce more viscerous secretions. Therefore, it leads to thick and sticky mucuses. Most of the time, the lungs are the major ones that are affected, but also the pancreas, the reproductive system, liver, the skin, and the GI tracts are also affected. So most of our patients who live with CF, they go through a variety range of treatments. So they include nebulizations, IV antibiotics, steroids. They also have physiotherapy and airway clearance. We like to do roughly about 30 minutes for at least twice 2 sessions. We also have dietitians who work with their diabetes, just their weight management. We also have mental health as one of our treatments as well. So when a patient comes in for care, these are just a few of the things that we do assess and look into. So we check their weight, we check the blood glucose levels, just if they are taking prednisone when we do need to give it to them. This will help monitor their levels. IV access, which we'll talk about later. We've got central lines, we've got PICC lines. We also use portacaths with our patients. And this also helps us to maintain home IVs when we do send them home. So like I said, we've got IV antibiotics that we do give them. There's medications which they take, such as Creon. We also do oral antibiotics. Sputum, we make sure, hemoptysis, and we make sure their bowels are regularly going well. So just moving on to how we use antibiotics and the use of the infusion packs and electrometrics. CF, like I said, does cause an abnormal amount of mucose secretions in the airways. If this is persistent, then inflammation, airway damage, deterioration of the patient can occur. Therefore, we do bring in our patients for a course of antibiotics. These can range from a 14-day admission to a 10-day admission, just depending on where they're sitting out based on their lung function, their health, and overall plans that we've had as a group. There are some cases that because of specific antibiotics we need to choose, we might get the infection disease team consulted as well, just to look up further sensitivities for patients. So some of the most common pathogens that we see in our patients are Pseudomonas, staph. We see a lot of Haemophilus as well recently. So they're our major ones. And we also do have non-TB microbacteriums. So the way we treat our patients, we do look at what they grow. So depending on what they grow, also tells us which agents we're going to use. So depending if it's sensitive, if it's resistant, we'll just choose which one we're working with. We do usually use dual agents. So we do, alongside antibiotics such as Keftaz, Meropenem, Tazocin, we do use tobramycin when we give the Pseudomonas patients. So we do use those two agents. Most of the time, to decide what we're using, we do use sputum samples, as that's our most, you could say, easiest way of trying to see what they're growing. But we also do sinus samples. So recently, because of the treatment with CF, we've had a lot of patients who do not cough up anything anymore, and it makes us harder and harder to see how we can treat the patient, which antibiotics to give. So we do sinus samples as well, and that sort of give us like a guide and to work out what is growing in the chest in order for us to treat this. So our physios came up with a sinus culture protocol that which we use here to gain samples, send off like we do with sputum samples in order to find out what they're growing. So just moving on to, we have a home treatment program. So we use a home treatment program along with HEAP as an early discharge program. So with this, we sort of can see that a 14-day admission to a 10-day admission can have major effects on our patients. It can be quite draining mentally, exhausting. They're away from family, they're away from friends. It just interrupts their whole system, whole lifestyle. So we do have a early discharge program, which means that in a couple of days they come in, have admission for maybe 4 or 5 days, have sort of like a reset. So we would go through physio again. We'll make sure any specific teams that need to see them, we'll get them seen, and then we send them off home with obviously these electrometrics, which enables them to go home, have normal lifestyles, be able to continue their treatment. Like I said, be close with family, helps their mental health as well. And this also affects the hospital admission stay as well. So in order to send patients home with these bottles, we do education. We just got to make sure that they do have enough support, their IV access is decent and well, and of course adherence with other treatments as well. Before we had these we use Baxter, I should just say. Before we have these Baxter infusers, a lot of our patients were having to make their own medications at home. And obviously this is a bit of a safety risk if they are taking it home, or even the HEAP nurses taking it there, making it up, and attaching it to an IV pole, letting it go through. So recently, as it's all changed now, we do use these infusion devices which help us continue the IV access, IV medications at home. This just allows them to, like I said, continue on their day-to-day life. They still get their treatment. They do still come and see us on a regular basis when they are on home IVs. Different companies, like we see here, do have different types of devices, depending on medications as well. So we tend to have our patients pick up the antibiotics if they are doing it on their own. This allows them to come back to the clinic, get seen as an outpatient. We'll have regular check-ins with the physios, doctors, just making sure everything's running smoothly, and that there's no issues with their infusions, their lines, or if they do need any more checks in between. So each antibiotic that we have, currently, this table just shows how often we can use or how many days we need to reorder them in. So as we can see, our antimicrobials are on one side, and this is what we use to order our drugs for our patients. So the most common ones that we use are Keftaz and meropenem and Paylosin. We do use tobramycin, like I was saying, whereas they have a shelf life and can be ordered in a max, and we'll have 21 infusers you can order. But because our patients only need 14 days worth, we can just order 14 at once. We do tend to order the minimum, just because it allows our patients to come back to us and we can monitor them and make sure they are doing everything well. This is just another example of how we use our home treatment program. We just order it this way. It goes through to our pharmacy. They order it through the company that we use. This then comes to us, patients pick it up, and we finish off their IV antibiotics this way. Just wrapping up a few things, like I was mentioning, the process of our HTP. We usually use it as an early discharge program, and we just continue the same antibiotics that they've been having in hospital. The orders get placed in pharmacy, the patients do pick it up, and when they do come in, they see a physio, they do a lung function. If there is a dressing change needed, we make sure the dressings get done. We also collect sputum for further culture to help us with further treatment options. We do also have a booklet that we give to our patients that show them how they can do the home IVs, how to use the bottles. It also goes through troubleshooting. So if there is any issues, who to contact. And again, we give them all their supplies. This also will be the same if he was with them. They would collect all their backs of bottles, do everything as well. But most of our patients are self-caring. We do teach them. We make sure that they're safe and teach them how to use all these devices, or a family member is able to do it. Yeah. So sorry, that was the rest of my presentation, but that was my presentation, and we'll have questions at the end.
I guess I was muted for those who were online, so I would like to repeat that, acknowledging the interesting presentation by Rachel, and in the interest of time, we'll progress to the next talk.